the chat box as of now. I can't see the chat box. So
Sir,
if
your
anyone
line
has any doubt, you can use the loudspeaker and just start asking question and then put your loudspeaker off. Okay. Anytime you can talk to me. Let it be very interactive session. Let's revise what we have studied in the previous classes. Okay. The first thing now today what we are discussing is mainly the X-ray physics. Now, the X-ray physics becomes very important for your the entrance test. Why? First thing is it is very easy. It's very easy to understand. The second thing is this is the place where they can make a lot of MCQs. And if you know the physics of X, it is very easy to answer these MCQs than any clinical questions. So that's why it's very important for us to understand the X-ray physics and their application as well. So we all have studied how the X-ray room is, which contains a X-ray tube and a table, and also there will be the control room, which will control the X-ray exposure. We have two parameters here. One is KVP and one is
so the
MAS.
screen is not
Both
visible.
are under our control. So this is how we use the X-ray machine. And we know that electromagnetic radiation is a transport of energy through the space in the form of electrical magnetic field, and we have studied Röntgen is the one who is considered as father of radiology because he used X-ray in the imaging and he discovered the X-ray in 8 November 1895. And we know that the radio waves, the microwaves, the infrared waves, and the visible light, all these come under the ionizing radiation. They have higher frequency, but they have so they have lower frequency, but they have higher wavelength. Whereas the gamma rays and X-rays are the ionizing radiation. If I ask which are the other ionizing radiations, it is alpha particle, it is beta particle, then it is the neutrons. So these are the other ionizing radiation. So mainly we need to know X-ray and the gamma rays are the ionizing radiation. It's all we have studied, and this is how the propagation of the X-rays, that is, it's a magnetic and the electrical field which are perpendicular to each other. Okay, so we also know that any charged particle has an electrical field around it. Okay, it has an electrical field around it, or any moving charged particle has a magnetic field around it. So any charged particle has electrical field, moving charge has magnetic field, whereas an accelerating charge, see how the accelerating charge or decelerating charge will produce this electromagnetic radiation. So we have to remember that any charged particle has electrical field, moving particle has a magnetic field, accelerating charge has a produces an electromagnetic radiation, and that's how it was introduced. And then we also knew that in an atom, the central nucleus will be there, then the K shell, then the L shell. So as we go outside, the energy of the shells increases. The energy of the shells increases as we go outside. This is a very important concept we need to remember. Okay, now what happens whenever an electron, how exactly if you see the X-ray tube, this is how an X-ray tube works. So this is how an X-ray tube, it will contain a vacuum inside. It contains vacuum because there should not be any air molecule. If there is any air molecule, the electron movement will be disturbed by this air molecule. That much you have to remember. Okay, and whenever we pass current through this the vacuum tube, the electrons will be thrown out from the cathode to the anode, and when the electrons hit the anode, it will produce electromagnetic radiation. This is the principle. Now how exactly does this? Now one thing, whenever this is an electron, this is an electron, this is an electron, whenever I shoot it into the atom, it will be decelerated by the nucleus, and that's what produces electromagnetic radiation. This type of electromagnetic radiation is called as the Bremsstrahlung radiation. Okay, this type of electromagnetic radiation is called as a Bremsstrahlung radiation. Similarly, I have also told you that if the electron shift the inner shell electron outside, then what will happen? The higher energy electron jumps inside. Now the difference in the energy is given as the electromagnetic radiation. Now this is called as a characteristic radiation. It's all we have discussed previously. And we know that the maximum effect is by the Bremsstrahlung, and only the minimal the effect is by the characteristic radiation. So if in case the question is in an X-ray, which is a predominant type of X-ray production, is it Bremsstrahlung, is it characteristic? Answer is it is always Bremsstrahlung. Okay, now this is an anode, this is a cathode, both are made up of tungsten. Okay, both are made up of tungsten. Now tungsten is used in both the cases because whenever an electron hits this anode, it should not damage, it should not get damaged. That's why I have used tungsten. Why do I use because it is having high tensile strength. Now why do I use tungsten in the cathode? I use tungsten in the cathode because it is having very high melting point. Whenever it is having very high melting point, what happens when it has very high melting point? Whenever it has very high melting point, we can heat up these filaments into very high temperature. The electrons will be thrown out. Now these electrons will go and hit the anode, and that is what is producing the electromagnetic radiation. So why do I use tungsten in the filament? Because it's having high melting point. This is also we have discussed in the previous classes. And we also know that nowadays we use a rotating anode. Why do I use rotating anode? Because I don't want to have this pitting effect, or because of rotating anode, the heat dissipation is faster. The heat dissipation is faster. That's why I use a rotating anode. This again we have discussed in the previous class. And also there will be a focusing cup which will focus all the electrons into the anode and prevents the dispersion of electrons. And we use vacuum because if you don't use vacuum, some of the electrons which is supposed to go produce some X-rays will go and hit this what air molecules, and it is responsible for extra electron production.
Slides
And
are not
also
seen.
the velocity of these electrons changes. So these
Hello,
are all bad effects of this
Prajwath?
air molecule which is responsible for all the effect. Just a minute. Hello. Pole, pole, amigo, pole.
Slides we are not seeing.
Yeah, yeah, pole. Okay, so that's how we used a focusing cup we had used, and that's what
Slides.
was responsible for the focusing the electrons into the anode. Okay, so again we have seen how the electron produces electron is produced in the filament. And also one more thing that we have discussed in the previous class, there is this filter made up of aluminium. And what is the use of these filters? It will reduce the low energy radiation. It reduces the low energy radiation. That is very important. The low energy radiation is reduced by using this aluminium filter. And we have beams restrictor, that is the collimators and the cones. So this will reduce the scattered radiation. Again, we have discussed all this. Okay, so use of filter is nothing but it will reduce the low energy X-rays from passing through. So this is nothing but the grid which is present between the patient and the image receptor. What will grid do? Grid will prevent the scattered radiation. It will prevent the scattered radiation. Now also if you go further, we know that how when the X-ray hits
Sir, slides are not visible.
the fluorescent screen will become bright, and whenever the fluorescent screen becomes bright, it will expose this X-ray film which is made up
Sir,
of silver
slides are not
bromide and
visible.
silver iodide, and this will convert itself into black color because of the ionization of these molecules. This is what we see whenever there is X-ray exposure to the film. So this is, and also one more thing, one more question is usually asked: what is a window which is made up of? Okay, this entire tube is made up of Pyrex glass. This tube is made up of Pyrex glass, whereas this window is made up of beryllium. Okay, window is made up of beryllium. Why we use beryllium? Because it will not interact with an X-ray. Now, hello, sir.
Slides problem ಆಗ್ತಾ ಇದೆ ನೋಡಿ ಸರ್.
Slides ಕಾಣಿಸ್ತಿಲ್ವಾ sir? Oh, okay. Okay, okay, sir. ಇಲ್ಲ ಇಲ್ಲ ಲ್ಯಾಪ್ಟಾಪ್ ಇದು. ಇಲ್ಲ ಇಲ್ಲ ಇಂಟರ್ನೆಟ್ ಪ್ರಾಪರ್ ಇದೆ ಸರ್, ನಾನು ಸಿಟಿಯಲ್ಲಿ ಇರೋದು. ಅದು ನಾನು ಫುಲ್ ಸ್ಕ್ರೀನ್ ಇದನ್ನೇ ಸ್ಕ್ರೀನ್ ಮಾಡ್ತೀನಿ ಸರ್. ಓಕೆ, ಅದೇ ಫುಲ್ ಸ್ಕ್ರೀನ್ ಶೇರ್ ಮಾಡ್ತೀನಿ. ಅದೇ ಬೆಟರ್ ಅನ್ಸುತ್ತೆ ಅದು. ಓಕೆ, ಅದೇ ಬೆಟರ್ ಅನ್ಸುತ್ತೆ. Can you guys see my slides now? ಸ್ಟಾರ್ಟಿಂಗ್ ಇಂದ ಮಾಡಲ ಸರ್ ಮತ್ತೆ? ನಾನು ಇದು ರಿವೈಸ್ ಮಾಡ್ತಿದ್ದೆ ಸರ್ ಪ್ರೀವಿಯಸ್ ಕ್ಲಾಸ್. ಓಕೆ 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 okay. So guys, I think my slide was not visible. Should I continue from the same spot or should I start from the beginning? I was revising the previous classes, so if you guys already know these things, I'll continue with the same slide or I'll start from the beginning. So what do you guys want me to do? Can you please type in the chat box? I continue from the same spot. Okay. Okay, Sakshi is telling to continue from the same place. Okay, I'll continue from the same. Okay, any other opinion? Okay, no one has given any other opinion. Okay, I think Sakshi is following my previous classes, so okay, we had also discussed about the quality of an X-ray as well. Okay, so the beryllium window was what was used. Then two important factors that we have to understand. One is a KVP, one is MAS. So if you have any problem, please use the voice chat. Okay, just give me a voice chat because I cannot see the screen. I think at least if you raise your hand, I can see. Okay, if you raise your hand, I might be see. I'm not sure. But if you talk to me, I think I can hear, but I am not able to see the PowerPoint and the chat box simultaneously. So any doubts you can ask, use the voice chat because there are not too many people now. Like it won't be that disturbing. So if you have any doubts, please be free to ask, okay, at any point. So we have two factors. One is the kilovolt potential KVP.
Excuse me, sir.
Now, what exactly KVP is? The KVP is the potential difference between the anode and the cathode. So this is the anode, this is the cathode. The potential difference is nothing but the kilovolt potential. The potential difference is nothing but the
Sir, you start from the
KVP.
beginning only, sir.
What is MAS? MAS is the amount of current that we pass through it. So the MAS is nothing but the amount of current that we are passing across this filament. What will happen if I pass more and more current? Now there will be more and more electron which is produced. Okay, more and more electron that is produced here. Now what happens when there is more and more electron which is produced? This electron will move towards the anode. Okay, this electron will move towards the anode, and this is responsible for the hitting the anode and production of X-ray. This is what we have to keep in mind. So KVP is directly proportional to the energy of X-ray. Why? More the potential difference across the two ends, more is the speed at which electron moves. Okay, this is what we have discussed previously. Also, whenever there is more energy in an X-ray, what will happen? It will penetrate more, it will have more power, so more penetration. And also I have explained you how if there is more penetration, the contrast reduces. Okay, so more the penetration, the less is the contrast. But what happens if I increase the MAS? Number of electron increases. The number of electron increases, the number of X-ray increases. When number of electron increases, number of X-ray increases. Now when number of X-ray increases, the contrast between the tissue increases. So the contrast between the tissue increases whenever we increase the MAS. So for having a good contrast, I have to reduce the KVP or I have to increase the MAS. But if I ask you one factor that if I want to change, I will always change a KVP. But once there was a question which said that in a fat patient, I want to improve the contrast, what will I do? I cannot reduce the contrast. We have discussed this last class. I cannot reduce the KVP. If I reduce the KVP, penetration decreases. So what I have to do? I have to increase the MAS. So this is how we can modulate the KVP and MAS. Okay, so the same thing that we have discussed. Also, that's how the screen film radiography, till now whatever we discussed is the screen film radiography. It is made up of silver bromide or silver iodide screen. Now what we are having is the cassette radiography or computer tomography, in which computerized radiography, in which whenever X-ray is exposing the cassette, the electrons will be going from lower energy to higher energy. Now, once this exposure is done, what we do, I take this cassette and put it into the cassette reader. When the cassette reader sends a laser beam, it will send the electrons back to the cassette, and this will release light, and this light is measured by the computers, and that's what is forming as image. So this is the cassette reader. So this is how the cassette. So what is the advantage of this? I can repeat this procedure as many number of times I want. Second thing, it can need do we don't have to be inside a closed room to do all this. We can carry this cassette around because it is only stimulated by the X-ray. It is not stimulated by the light. But later we came up with a digital radiography. Does this digital radiography works? Now there is no cassette. How this works? So this was more like a this is like a the hard disk, or this is like a hard disk or a pen drive. Okay, whenever we want image, we can put in this, then we can read it, and later we can erase it. So that's how the image is stored in. Whereas this one is like our the computer in which directly the camera in which directly connected to the computer. We have multiple types of detector. You don't have to remember these types of detector. So whenever the X-ray is exposed, it will be directly sent to the computer via wire. So this is a digital radiography. So we saw three system of radiography. One is a film screen radiography, one is a computerized radiography, one is a digital radiography. The difference is here we use the silver bromide, silver iodide with the fluorescent screen, silver bromide, silver iodide, and CR is a cassette radiography in which we had some chemicals here which will excite these electrons on cassette reader. When we expose it to laser, it will produce the image. Now digital radiography, whatever the stimulation which is received is directly sent into the computers with via the wires. So there is very fast, this is a very fast technology and the very recent advances. So that is a direct digital radiography. And also very important, which I have taught you in the previous class. So this is the last topic that we discussed in the previous class, but I want to revise this very thoroughly because this is the most important concept. Now whatever I have drawn here is nothing but the X-ray tubes. Okay, on top we have multiple X-ray tubes I have drawn. Down I have drawn multiple atoms. So what I am representing is here is a low energy, and this is the high energy. If as I go towards the right, it is high energy. Now what happens when I send a very low energy X-ray, X-ray goes and it will stimulate an electrons, and this electron is set into vibration, and this vibrating electron is vibrating, it will release the energy as X-ray, and this X-ray, what we produce here is nothing but a coherent scattering. So whatever the low energy X-ray which hit the electron sets into vibration, and then this is reflected back. So this is a coherent scattering. Now similarly, when the energy is higher and it is equal to the binding energy of this inner shell electron, what is the binding energy? It is the energy that is required to eject this electron out. So that is the binding energy. It's a minimum energy that is required to eject the inner electron out. That is called binding energy. So whenever the energy of X-ray is equal to the binding energy, what happens? This electron will be thrown out. Whenever this electron is thrown out, now what happens? Now the electron is thrown out. The outer shell electron wants to go into the inner shell because that's a lower energy state. But whatever the extra energy was present, it is released as X-rays. Now this is called as a photoelectric effect. So now in the photoelectric effect, the X-ray energy is equal to binding energy. In the initial stage, X-ray energy was lesser than the binding energy. Now, if the X-ray energy is more than binding energy, what happens that we need to know? So when the X-ray energy is more than binding energy, the X-ray comes, stimulates, throws the outer shell electron, and it will get scattered itself. Okay, the same X-ray which came here gets scattered. This is not a new X-ray. This is called as a Compton scattering. So in an X-ray tube, there is photoelectric effect, there is Compton effect, but there is no coherent scattering. Why there is no coherent scattering? Because I have kept an aluminum filter which will eliminate the low energy X-rays. So there is no coherent scattering in an X-ray tube, but there is photoelectric effect, there is Compton effect in an X-ray tube. Now what we have to understand is this is what we see in the diagnostic radiology. Okay, diagnostic radiology, there is Compton effect, photoelectric effect, coherent scattering. But when we see the very high energy of X-rays. So here we use 150 kilovolt of energy, whereas when we use very high energy as 1.02 mega electron volt of X-ray, very high energy X-rays, 10 times more than that of the diagnostic. That's when these effects happen, and this is nothing but it will go and hit the nucleus and produce the electron and positron. So this production of electron and positron is called as a pair production. Similarly, if the energy is very high, that is 7 to 15 mega electron volt, very high energy, now it can even remove nucleus, the neutrons, protons, or alpha particles from the nucleus. So this is called as a photo disintegration. See how the various effects that can happen whenever there is interaction of X-ray with matter. Now, see, there is some very important question. There might be a question in which they can tell where all there will be ionization of an atom. It is in the photoelectric effect, it is in the Campton scattering, where all there will be nuclear instability. That will be not in the photoelectric effect, not in the Campton, not in the coherent, but it is in the pair production and the photo disintegration. This is how the various question can be formed in this. So this is what we have studied in the previous class. Also, now what we have to understand is how a standard X-ray room will be. So this is how a standard X-ray this is how the standard X-ray room. A standard X-ray room contains a X-ray room, and attached to it there will be a room in which the controller will be standing, and then in this there will be X-ray tube. There will be the X-ray tube, and there will be table, and below the table there will be a film kept, or film or the cassette is kept, and that's how the imaging will be done. Okay, so this then along with the X-ray we can also use X-ray for various other conditions. This is nothing but the C-arm. The C-arm is used in orthopedics. This is also used in the cath lab. Cath lab is not coronary artery examination we do in the cath lab. So cath lab also we use the C-arm, and various other places we can use this. For fluoroscopy as well we can use this. And also we need to know that in a mammography room also it uses X-ray as the source of energy, which is responsible for the image formation. Now if you see in this image, now this is how X-ray is performed. Now this is nothing but the X-ray tube. This is the X-ray, this is the compressor, the breast compressor. Now here is the breast place. So breast is placed like how we are depicted here, like a ball. It is placed here in between this compressor and the X-ray film, and then there will be compression of this breast will be done, and then we expose the breast and we get an image. So this is how mammography is done. So mammography is one of the commonest imaging modality which we use more than 40 years of it. The new guidelines say more than 45 years of age, and this is how we do the mammography. But what is important now is which are the other modalities that we can do. This is mammography. Then we can also give sonomammography. That is nothing but an ultrasound of the breast is called as a sono. Sono means sound. Mammo means breast. Sonomammography is nothing but the ultrasound of the breast. This is also we can do in case of a breast examination. Also we can do MRI examination of the breast. Okay, we place a breast in the MRI room. The freely hanging, it should be freely hanging down, and then we inject the contrast. Then we do multiple imaging sequences using the MRI machine. So this is nothing but MRI mammography. So we had ultrasound mammography, then we had X-ray mammography, then we are having MRI mammography. Sir, your slides are still not. Am I not visible? Is my slide visible or not visible?
Visible, sir.
Slides are visible actually. Some people are telling you're not visible. I don't know.
Is my slide visible?
Yes, sir. For me, it's visible, sir.
Now you are come to me, sir.
Hello?
They are visible.
Hello?
Slides are visible. Slides are visible.
Hello.
Shivani,
Slides are visible, sir.
they are
Slides are
visible.
visible.
Go ahead.
Okay. Okay. Okay, so then we had the MRI mammography, and then if you go further, we also have the PET imaging, okay, in which the breast is kept in the PET machine, and then we see the changes in the breast, and this is called as the PET mammography. So it is similar to any other PET. We can see a bright spot. The bright spot suggests that high metabolically active area. Whenever there is high metabolically active area, the FDG uptake is higher here. Okay, 5-fluorodeoxyglucose is uptake high here. And also there is something called tomosynthesis. Tomosynthesis is nothing but the X-ray tube will be moving from one end to other end, and the X-ray beam will be coming from multiple directions, and it will form an image, and this will give us multiple slices of image. Okay, multiple slice image. So that is tomosynthesis. That is nothing but a mammography in which we have multiple directional projections. Okay, then we have thermography. It uses the heat energy which is present in the breast tissue, and this is the newest modality. So these are the modalities that are used in the breast. So if in case an MCQ comes, all of the following are the breast imaging except. So mammography you use, ultrasound we use, that is nothing but sonomammography. MRI we use, that is MRI mammography. PET also we can use. Tomosynthesis and thermography are also the techniques that we use in the breast. So that's what we need to remember here. So normally a breast contains fat, and also breast contains the glandular tissue. Okay, breast contains the glandular tissue. So breast contains fat, breast contains glandular tissue. Okay, two things. Okay, fat and the glandular tissue. What we have to understand is the X-ray is all based on the density. Okay, X-ray is always based on the density. Higher the density, whiter it looks. Okay, higher the density, whiter it looks. Lower the density, blacker it looks. Okay, higher the density, whiter it looks. Lower the density, blacker it looks. So this is soft tissue. This is the fat. Now whenever you see fat, it allows more X-rays to pass through it, so it will appear more blacker. The X-ray film appears more blacker. The soft tissue will allow less X-rays to pass through it, so it will appear less blacker. So if it is more blacker, then it is fat. If it is less blacker, then it is soft tissue. More blacker, then it is breast. Less blacker, that is then is soft tissue. So here we can see whatever we are seeing here. This black area is nothing but the fat, subcutaneous fat, and deeper here we can see even the glandular tissue, and the whiteness is because of the glandular tissue. Okay, whiteness is here because of the glandular tissue. So that's what we see in this craniocaudal weave. And now there are two weaves that we see do in a breast mammography. Very important. We do two weaves. So if this is the breast, okay, these are the two breasts. If I compress the breast from the above downwards, then it is called as a craniocaudal weave. It is called as a craniocaudal weave. If I compress it from the medial to lateral, so it is called as a mediolateral weave. Okay, so but mediolateral weave we always do oblique section, so it is called as a mediolateral oblique. So we know that by this slide. So the breast imaging can be of mainly two types, that is the craniocaudal or the mediolateral oblique. Also sometimes we can do some rotating mediolateral view or rotating craniocaudal view, or we can do a cleavage view. Whenever we do a cleavage view, we will keep the cassette and the X-ray tube in the middle of the two breasts, so it will see the medial end of the both breasts. So these are the different views, but predominantly we do a craniocaudal view. Whenever you compress from above and below, it's called craniocaudal view, and this is how we can see two images. We'll be seeing the right craniocaudal, left craniocaudal we are seeing. And in this image, we can see that there is mediolateral oblique. What is the speciality of mediolateral oblique? We will see this pectoralis major. This dense area is nothing but the area which is formed by the pectoralis muscle. So pectoralis muscle suggests that this is a mediolateral oblique, or it is a left or right mediolateral oblique. So that's what is suggested by the pectoralis major muscle. Okay, if you see this pectoralis major like this, that means that this is the mediolateral oblique view. And again, we can see that this is the nipple and this is the skin. And then we can see that the two breasts, we can see very clearly by the mediolateral oblique. And this area is correspond to the axillary tail of the mediolateral oblique view. Now, if you go to the next image, now in this image, what we are seeing, in this image, we can see that one is the mediolateral oblique view, one is the craniocaudal view. Now, what exactly we see in the mediolateral oblique view? We can see that there is the pectoralis muscle. There is no pectoralis muscle seen in case of the craniocaudal view. And if you see here that this is the skin surface, this is skin surface, and along with the skin surface, we can see this is the mammary tissue. So it's also called as corpus mammae, and this is the pectoralis muscle we know. Also, we can see some septations in the subcutaneous tissue that is called as crests of Duret. Okay, the septations here is called as the crests of Duret. See here, there are multiple septations in the subcutaneous fat. So these are nothing but the crests of Duret. Okay, so that is the crest of Duret. And deeper to this, the corpus mammae, we can see a retromammary retromammary fat. This is called as a Chesignax bursae. Okay, this is called as the Chesignax bursae. So this is what we see retromammary space. Okay, so this is again a full-fledged image of a craniocaudal view with the two breasts, and this is a mediolateral oblique. So very important to understand, any image, this is always right, this is always left. Same way here, this is always right, this is always left. We don't have to tell that. And also we know that this is always medial, this is always then we need to, so this is how we divide initially, right and left is always fixed. Then we know that this is always an outer quadrant. Okay, upper one is always an outer quadrant, and this is always an inner quadrant. So whenever we compress a breast in the craniocaudal direction, we have two parts of the breast. One is outer quadrant, one is inner quadrant. Now, whatever is the outer quadrant is always up in the upper part of the image. Same way in the mediolateral oblique view, whenever we compress like this mediolateral oblique view, it is again divided into upper half and the lower half. Now, upper half is always outer. Okay, so upper is always outer, or outer is always upper. Okay, so in craniocaudal oblique view, whenever we compress like this, the outer quadrant is present in the upper part of the screen. Similarly, when I compress it like this, it is having an upper part of the breast and lower part of the breast. The upper part of the breast is always kept in the upper aspect. So if you have any doubt in this, please be free to ask, because mammography is very important for all your practical purpose as well. So just feel free to ask if you have any doubt here. Okay, now these are the standard views. The craniocaudal and the mediolateral oblique is the standard view. Then various other views we can give: the cleavage view, the axillary tail view, the oblique, the rotatory views. All that's not important. What is important here is now if you see this image, we can see that some specimen, it looks like it is a resected specimen. So this specimen is nothing but it is a post-operative specimen in which we have kept a needle here. So what is this exactly? So before doing a resection of any breast image, so if you see in this image, so this is a pectoralis major, is a normal breast. What I have done, I have kept a needle at the site of a tumor and then ask the surgeon to operate. Now what he does, he will give a good margin around this needle and then operate, so that the margin is very good. Whenever we operate, the margin will be very good, and we will not retain any tumor tissues there. So once I resect it, whatever I'm getting here is the specimen mammography. So here this is the specimen mammography, which has been resected because of this lesion, which is coded by we keeping this wire inside. So this is called as a specimen mammography. So what did we study today? We studied that mammography. We studied mammography views. Mammography has two main views: craniocaudal view, mediolateral oblique view. And the mediolateral oblique view has upper part and the lower part. Craniocaudal view has inner part and it has an outer part. The upper part or the outer part, both are present in the upper aspect of the X-ray film. So that we have to remember. And then what did we study? We studied that there is two things. One is the wire localization. Wire localization, that is nothing but we keep a wire in the breast tissue, in the lesion, and then take in mammography, and we get to know what is where is the lesion while operating. Now, similarly, we can do a specimen mammography to see that whether I have completely resected this wire localization. So that's the two things. Okay. Now this is nothing but a dense tissue that you are seeing here is nothing but the breast implant which is present here. Okay. Now the reporting system in the breast imaging is becomes very important. This is called as a BIRAD system. Okay, breast imaging and reporting, breast imaging, reporting, and data system. Okay, so this is nothing but the BIRAD system, breast imaging, reporting, and data system. So this is the BIRAD. Why is this done? This is done to standardize the patient care and the physician communication. What used to happen? There is some lesion in the breast. Okay, this is a breast. There is one lesion in the breast. Different people started describing it differently, and whenever a doctor tells a patient, he doesn't know whether it is a bad tumor or whether it is a good tumor. So we don't know what it is. So what do? I use this BIRADS reporting system, so which has standardized the reporting, in which whatever I tell you, it means something, and that means very specific thing. It can be used in mammograph, it can be used in ultrasound, it can be used in MRI. But what does BIRAD stand for? So BIRAD stand for, if I give a score of 0, that means it needs further evaluation. It's of no use reading this. If I give a score of 6, that means it's already a known case of malignancy. A biopsy is already proven. We don't have to report BIRADS as such. Okay, so that is the 6, and this is 0. 0 means it is incomplete evaluation. Mammography is not enough to just diagnose the disease. So that is 0 and 6. Now, if you see 1, what is 1? 1 is negative. That means there is no lesion at all. Entire breast appears normal. But if I see a well-defined rounded nodule, looks like breast fibroadenoma, which is an benign condition, breast fibroadenoma, a benign condition, then we give it a grade of 2. So BIRADS 2 is nothing but a benign lesion in the breast. We are very sure it is benign lesion. But when do I say it is probable malignancy? So if there are even a small feature which may make you think that it is malignancy, then we give a probably benign. When do I say suspicious of malignancy? When the chances are very high, like it is looking more like a malignancy, less like a benign, then I give a suspicious of malignancy. Very highly suspicious of malignancy we give when there are no signs that are supporting a benign lesion. We give highly suspicious of malignancy. So what is the important of all this? So if it is negative, if it is benign, less than 2%, there is no chance of malignancy. But if it is less than 2% also, I mean, in probably benign conditions, it will have around 2% cases of malignancy. But if it is more than the 2% cases of malignancy, then it is coming under suspicious of malignancy. So here it is more than 2%. So if it is more than 90%, then it is highly suspicious of malignancy. So the BIRADS reporting system, it can be 1 or 2. If I report 1 or 2, that means no suspicious of malignancy. Then that means that we don't have to do anything. Just continue this patient like he didn't have anything. But if I give a grade of 3, that means you're telling it is probably malignancy. That means that they are still 2% chances of becoming less than 2% chance of becoming malignancy. Still, I didn't say that there is no chance of malignancy. So that's why this needs a faster follow-up. But if I say that highly suspicious of malignancy or suspicious of malignancy, then I will always want to do a biopsy. Okay, so grade 4 or 5, always do biopsy. Grade 3, short-term follow-up is enough. But still, if you feel like it is suspicious, then you can do a biopsy. So BIRADS in the breast. Okay, so BIRADS consider various factors which is to see the breast imaging. Whenever you do BIRADS in an X-ray, it sees the various factors. One is a breast density. Okay, breast density. So how do I access a breast density? So now whenever there is a breast, what we see how much is the fat content. See, there is no fat content. So there is predominantly fat content. If I go here, it is more of a the scattered glandular tissue. If I go further, the younger breast, there will be predominantly glandular tissue. And if you see in a teenager, it is extensively glandular. What happens if there is a fatty breast like this? Even if a small nodule is present here, we can see very clearly, we know it is a malignancy, or if you know it is a malignant or benign tumor. But if it is the same lesion is present in this highly glandular tissue, it looks like a part of the glandular tissue, and we cannot differentiate sometimes, and we might miss these lesions. So that is the importance of telling the density of the breast in the images. So if you say the density of the breast in the images, and then that will help us to understand how much is the impact of this imaging modality. And once we see how much is the density of the breast, now the next thing that we have to see is the shape of the lesion, the density of the lesion, the margin, and the calcification. Now again, density, when it comes to the density, if it is hyperdense, it is more towards a malignancy. When it is hypodense, it is more towards a benign lesion. So hyperdense is more towards a malignancy, hypodense more towards a benign. The shape, if it is round, more towards benign, oval slightly more towards benign, and then but if it is irregular border, it's more towards the malignancy. So it is the density, it is hypodense, then it is benign. The shape, if it is round, it is benign. And then the margins, if it is completely circumscribed, more towards benign. If it is partially obscured, okay, if it might be circumscribed, but it is partly obscured by other tissues, then again it is bad. It is obscured, margin is present. But if there is lobulations, microlobulations present, now this is a sign that is suggesting towards malignancy. Or if there is a border which is not seen at all, if there is a border that is not seen at all, okay, border is not visible. When the border is not visible, then again it is highly suspicious of malignancy. And then the third one is if it is speculated. Okay, if it is speculated, then it is highly towards malignancy. So if it is having speculated margin, indistinct margin, or the microlobulated, think of malignancy. Calcification, if it is any gross calcification, think of benign. If it is fine, minute calcification, it's malignant. So we know that the low density favors benign, and high density favors malignancy. And also the shape, we know again the round favors benign, the irregular shapes malignancy, and the well circumscribed benign, and obscured is benign, whereas microlobulated, indistinct, or speculated, these three things are nothing but the malignant conditions. Now, if you go see the next image, so we can see the calcification, different types of calcification. Just remember that if it is fine pleomorphic, fine linear, fine branching, amorphous, or co-carcinogenous, the only four terms which suggest malignancy. So it is, if it is fine, if it is amorphous, if it is core. Why is this like this? Because tumor is growing very fast. When the tumor is growing very fast, it doesn't have time to deposit a lot of calcium and forming a calcific plaque. So that's why there is no, whenever these terms come, think of malignancy. But if there is a vascular calcification, skin calcification, popcorn calcification, plasma cell mastitis, or any of these things, or eggshell calcification, dystrophic, or the sutural calcification, then we think of a benign condition. So that's what becomes very important here. So again, we have discussed the same thing. Typically, benign calcification is a skin calcification, the milk of calcium. Can you see the milk of calcium forming this straight line in the upper half, but the convex border in the lower half? So this is the typically a milk of calcium. Then we have the rod-like calcification, dystrophic calcification will be there, and the popcorn calcification seen in fibroadenoma, rim calcification, Again, it is post hematoma, everything we can get vascular calcification is what we see here, rounded calcification, and the punctate calcification. So these are the different types of calcification that we see. And also, we need to know that whenever there is amorphous calcification, fine pleomorphic calcification, or coarse heterogeneous calcification, these are the terms: fine, amorphous, coarse. These are the terms when we see think of malignancy. Okay, abnormalities that indicate in the breast tissue is the architectural distortion. That is, it is pulling the nipple, pulling the skin tissue, puckering, dimpling. All these are malignant potential. That is architectural distortion. Microcalcification, fine stippled calcification, clear, fine amorphous, fine pleomorphic. So all these type of calcification or a speculated mass. So these are the three things: speculated mass, microcalcification, architectural distortion suggest towards malignancy. Mammography can also be done in males. It is not always done in females. The mammography is also done in males, and this is called as the male breast mammography. And again, this is how we are supposed to see. We are supposed to see only fat. Okay, so we can suppose see pectoralis major like this, and then there is only fat. But not supposed to see any glandular tissue like this. If you see any glandular tissue like this, it is nothing but the gynecomastia or the male breast. So that's about the mammography. I hope you guys understood. Do you have any doubt based on the mammography images? So if they will try to clear some doubts in the mammography, and then we'll go further class. So this is the second half of the X-ray physics and little bit about mammography. So any doubts you can ask in 2 minutes, then otherwise we'll continue with the next class. So any doubts, anyone has any doubts, please be free to ask me. Okay, anyone, any doubts? Okay. As no one is having any doubts, so we are further continuing with the class. So different X-ray views of the head. Okay, I have to go fast because we have to finish a lot of topics. So first thing is a cardwell view. How do I do a cardwell view? So this is an X-ray tube. Okay, it's an X-ray tube. And this is an X-ray tube. This is a detector, and I place the patient like this. Now, important thing to identify which part of the body is in contact with the image receptor. That is the face and the front of the head. When the face or front of the head is in contact with the X-ray tube, this always we have to keep very clear. That is very important concept, is that whenever I keep keep your hand away from the light, and then we make a shadow on the ground. As I take my hand closer and closer to the shadow becomes darker and darker. As I go away from the shadow becomes lighter and lighter. This tells us that the sharpness of the shadow and the size of the shadow all becomes equal to that what we see in the body whenever that part of the body is closest to the film. So in this kind of image, that is a posterior anterior view, the anterior structures are very clearly visible, and this is how we do a Caldwell view. The occipitomeatal, this is the orbitomeatal line. From the orbitomeatal line, the X-ray tube is moved cranially, and with the cord occipitofrontal weave is the angulation of 20 degrees is given. Okay, a 20-degree angulation to the orbitofrontal weave in a posterior anterior direction is the image of the Caldwell image. We get an image like this. What is very important in this image is that we can see that this structure is nothing but the petrous edge. Okay, this is nothing but the petrous edge. So very important to note is that this petrous edge is responsible for covering the lower half of the face. We cannot see the maxillary sinus clearly. We cannot see the orbit clearly. So that is about the caudal weave, which causes the petrous edge to overlap with the inferior orbit and the maxilla. This is responsible for the obscuration of the inferior part of the orbit. What becomes important in this is we can see the frontal sinus, we can see the superior orbital fissure. These are the two important structures that we can see here. Similarly, if I give one more PA wave, but here the patient head is extended, such that the orbitomeatal line will form a 45-degree with the image receptor. So we keep the patient's head with the orbitomeatal line 40-degree or 45-degree upwards, making an angle with the image receptor and sending the image from posteriorly. Now, this is called as a water sweep. So what is the difference between water sweep and the caudal weave? In water sweep, we are cranially angulating the X-ray tube and projecting it into downwards. Whereas in case of water sweep, the tube is remaining the same. I am rotating my head in the 45-degree. In the caudal view, the angulation is 20-degree. In the water view, the angulation is 45 degrees. So are the these are the two types of views, the caudal view and water view. What is the advantage? Now here the petrous apex is pushed down. So this is where the petrous apex is pushed down. So we can see the inferior floor of the orbit very clearly. We can see the maxillary sinus very clearly. So it is very useful to see the maxillary sinus and the floor of orbit. Also, if you do an open mouth view, also called as the Peary's view, we can also see the odontoid process as if you have the closed mouth view, we can see the odontoid process. The similar X-ray, if I do with an open mouth view, it is called as a, so this is closed mouth. If I do an open mouth view, now it is called as a Peary's view. Now the advantage of this is that whenever we do this open mouth view, we cannot see the odontoid process. What we can see here is a sphenoid sinus. And so whenever we want to see a sphenoid sinus, we do a Peary's view. An open mouth waters view is what we do. And if this is just a modification of waters view, everything else is same as that of our waters view. Advantage of this is we can see the sphenoid sinus, which we are not able to see in the previous view. Again, one more view, which is the posterior view, is a Rees view. What we do here, the angulation is very straight along the occipitomeatal line itself, but it is having an oblique direction when we see in this plane. And this view is mainly done with a 40-degree angulation of the face and then 15-degree angulation of the tube. So this view is mainly done to see for the optic foramen. So this is how we can see the optic foramen. So this is nothing but the superior orbital fissure, and then it's a superior orbital fissure. The optic foramen is nothing but the roof of the ethmoid, and the ethmoidal sinus is what we see here. So Rees view is done to see for the optic canal. Optic canal is seen in the Rees view. So this is one more view. So this is a Rees view, superior orbital fissure, and this is the orbital, the optic canal. So this is how we see the Rees view. The Townes view is the one view which is not a PA view. So till now we saw Rees view, we saw Peary's view, we saw Waters view, we saw Caldwell's view. Again, we saw Caldwell's view, Waters view, Peary's view, and the Rees view. These are all the posterior view, whereas the Townes view is the anterior posterior view, again with an angulation of 30 degree. Again, this is used to done to see the planum sphenoidale, also done to see the foramen magnum. So these are the different structures that we can see in this view. The lateral view, it's very simple. We do a lateral projection. We can mainly see the sella turcica, where the sphenoid bone is there, and normal sella is what we see here. And also we can see the maxillary sinus, the ethmoidal sinus, the sphenoidal sinus, the frontal sinus. So all the sinuses can be seen in one view, that is the lateral view. Okay. So this is again the lateral view, the zoomed part of the sphenoid process, the area. So showing the posterior clinoid process. You can see the posterior clinoid process, the sphenoid sella turcica where the sphenoid lies, the anterior clinoid process, and this is the sphenoid sinus. So different parts of the sphenoid sinus that we can see in the lateral view. That's how we do a lateral view. Now there is a Schuller's view. Schuller's view is nothing but a lateral view with a cranial oblique direction, with a cranial angulation is what is done here. So this is nothing but the Schuller's view, and this is mainly done to see the external auditory canal, the mandibular condyle, and this is the mandibular condyle, and this is the fossa for the mandibular condyle. and this is also, so this tenuous weave is also a similar
Go ahead,
kind
sir.
of weave. So it's the last slide that I have for today. So the tenuous weave is also a PAV with an oblique direction. So this is also mainly done to study the mastoid process, and the it's mainly done to see the cochlear implants. So what we can see here is, if you draw a line, so this is nothing but the superior semicircular canal. If you draw a line perpendicular to superior semicircular canal, we always supposed to have the cochlear implant, which should be present inside this part, and then only the cochlear implant is at the right place. You just have to remember the Stenver's weave, which is done to see the cochlear implant. So these are the different types of the weaves in the PNS. We saw the occipital metal weave, Waters weave, the occipital metal with open mouth, the Pieris weave, the occipital, the fronto-occipital weave, the caudal weave, and the lateral weave, the lateral oblique weave of the orbit or the Reese weave, and the submento vertical weave. So these are the different weaves. And additionally, we saw the Schuller's weave, the Stenuous weave, other additional weaves that we saw. So that is about today's class. So I hope you guys liked it. If any doubts, please let me know. It's I have 2 minutes left. I think we can keep the session open for any doubts. Okay, any doubts, please be free to ask. Please watch our previous classes as well, so that you guys can